Hi, my name is Nikki Schultek, and I'm the founder of Intracellular Research Group, here today hosting a series of discussions with scientists doing innovative and disruptive work. The series is called Brave Scientists, and today I'm very lucky to have with me Dr. Ed Breitschwerdt. So Ed is the professor of medicine and infectious diseases at North Carolina State University and College of Veterinary Medicine. He's also the adjunct professor of medicine at Duke University Medical Center and director of the Intracellular Pathogens Research Lab at the Institute for Comparative Medicine at NC State University. And also, with all of the work Ed has done, he's also co-founded a company called Galaxy Diagnostics. So today, Ed, we're going to be talking about stealth pathogens and chronic disease and ways that we can begin innovating to see the unseen, essentially, with these pathogens. So welcome, and thank you so much for joining me today. I really appreciate it.
Thank you, Nikki, and thank you for the invitation to share some of my experiences and some of the journey with everyone.
So you do have a really interesting journey that you took, and I wanted to start out just by asking you how you got started with Galaxy Diagnostics and sort of what kicked you off on the interest on the intracellular pathogens.
You know, Nikki, as I think about that question, we could start in 1992, or we could start about 10 years ago. I think I'm going to go back to 1992 because that's actually when Galaxy started in my brain, so to speak. And it was as a result of being at a research meeting in Hamilton, Montana at the Rocky Mountain Laboratories, which is quite famous for vector-borne infectious diseases. And it was the American Society of Rickettsiology meeting. And a rickettsiologist at CDC by the name of Dr. Russ Rignery had presented an abstract that said, we finally found the organism that causes cat scratch disease. And somewhat as chance would have it, because it's a reasonably large meeting, the next morning I went down to breakfast and ended up sitting with Russ and a couple of the other researchers from CDC. And I said, Russ, tell me a little bit more about this new bacteria and how hard it is to grow in the laboratory. Because before we started working with Bartonella, we worked with Rickettsia and Ehrlichia and Anaplasma and Babesia, all of which are intracellular organisms, and all of which are extremely difficult to work with in laboratory settings, extremely difficult to grow, and most importantly, extremely difficult to find in patients. So a lot of my career has been devoted to improving diagnostics to detect these intracellular organisms that do a very nice job of hiding. So I think the story of Galaxy actually started with Russ Rignery at CDC saying, we found the agent that causes cat scratch disease.
Yeah, and that's a way that a lot of amazing things get started, right? It's just some kind of interesting finding that grabs you, and then you continue to learn about it. So with your work, obviously we know that the pathogens that you mentioned are stealthy. They're difficult in a variety of ways to both identify and then get rid of once they're in there. But one of the things that is definitely sort of on the verge of being understood right now is we know that they can make you acutely ill, right? And there's definitely acknowledgement about acute illness with some of those pathogens, many of which are tick-borne, right, or vector-borne diseases, pathogens. But what about the chronicity factor? You know, the idea that the pathogens can stick around and continue to cause trouble at a chronic level.
Well, I think one of the transitions in my lectures to veterinarians and physicians was coming to the realization that most vector-borne organisms really do not want to make an animal or a person sick. They get there because a vector, be it a tick, a flea, a sandfly, a mosquito, what have you, decides to take a blood meal, and while taking that blood meal, injects or facilitates the transmission of one of these organisms. And once that happens, the obviously host, which let's say is one of us, has to make a immune response to try to block that transmission to stop the infection. I think many times that's successful and we don't even get sick. Sometimes it's not so successful and the organism establishes that acute infection that you talked about, and we get sick with an acute febrile illness would be the most typical symptoms that humans or animals would experience with these vector-borne infections acutely. And then again, I think many of us probably get over that without any therapeutic interventions or even seeing our physician, but some of us get sick enough that we seek medical care, and some of us get sick enough that we get hospitalized because of the severity of the infection. And I think that's all been pointed out very well with the COVID pandemic, that many people exposed, many people infected, most people not developing a severe illness, but other people developing, very severe illnesses and ending up on ventilators. It's really important, though, that some of those people that don't get sick with vector-borne infections do not eliminate the infection. And that leads to chronicity, and that leads to this constant interaction between the host immune system and the organism. And the organism is trying to hide, so we use the term a stealth pathogen, and the immune system is trying to either eliminate it or keep it in hiding so that it's not causing too much tissue damage.
That makes a great deal of sense. So the whole idea, essentially, that some of us have a different reaction to the same infection kind of is being highlighted, as you pointed out, with the COVID pandemic, right? And this is something that, has been observed really very long time throughout the course of medicine, right? That certain people can be carriers of even things like TB and not have a major issue, and then other individuals develop meningitis. And so it's that variability in the immune response probably is one of the pieces of the puzzle, right? To sort of figuring out who's going to get sick from a chronic infection and who may tolerate it.
Absolutely. And, again, in lecturing to our veterinary students in regard to infectious diseases, and this is particularly important in animals where breeders have often selected for phenotypic traits that are not the best traits genotypically to protect those animals against infectious diseases. So we clearly see some dogs, for example, that develop very severe parvovirus enteritis. We see some cat breeds that develop Mycobacterium avium intracellulare. And I think, what is true to a certain extent is that the genetics that we come into this world with as humans somewhat dictates how we go out. And we can modify that by drinking too much, eating too much, smoking too much, doing other things that compromise our immune response. But yeah, there's tremendous variation immunologically in the way that individuals respond to these organisms.
You just said that so well, I think, this interaction between what you can't control, right? Your genes when you get here, and then all the things that you can control, like lifestyle factors. And then, as I came into doing the work with Intracell because of my own illness, where I always joke that I think I was dealt kind of a rough hand in terms of the vulnerability piece to infections, because a lot of these things are ubiquitous. The germs that are being studied and with a relationship to chronic disease, things like herpes viruses and Alzheimer's, or chlamydia pneumoniae and Alzheimer's disease, those germs are very prevalent in the human population, and yet can be deleterious at times, it would seem the data shows. And then obviously there are individuals who may not be impacted. So as far as your work with Galaxy, talk to me a little bit about what you guys are currently up to, and maybe what you think needs to happen in the space as far as detection methods for pathogens like Bartonella, like Borrelia burgdorferi, aka Lyme disease.
So before I specifically address that question, I think it would be important for the viewers to understand that we started with the genus Bartonella after the announcement by Russ Rignery that, gee, we found the cause of cat scratch disease. So our initial research was Bartonella in cats, and we really wanted to understand how the bacteria behaved in a cat and how much risk there was in someone owning a cat that might be infected. And we're at least 25 years down the road, and we're still sorting some of those things out. But we do know that cats can be chronically infected for Bartonella with 3 years, and you can grow the organism out of their blood for 3 years. We then found the first Bartonella in the world to infect a dog, and that became a new Bartonella species. And then we literally, and again, it's because I'm a veterinarian and I'm kind of responsible for all creatures great and small, we wandered into the world of marine mammals. So we, to our amazement, found Bartonella in dolphins and beluga whales and sea lions. And ultimately came to, through what I was looking at clinically, and I would lecture predominantly to veterinarians, the realization that a lot of veterinarians occupationally are exposed to and infected with Bartonella. And so we've published a number of studies now, 2 or 3 from the United States and 1 from Spain, where veterinarians, some of whom are absolutely healthy in appearance, have Bartonella circulating in their blood. And of sick veterinarians, that can be up to 25 or 30% of the people that we've actually tested. So that journey from Russ's discovery of Bartonella henselae as the cause of cat scratch disease to my research lab, progressing through a lot of animal species and ultimately humans, led to us trying to develop better techniques to say a person or an animal was or was not infected with Bartonella. And that technique is based on molecular detection of the organism. But the unique aspect that we brought to the science at the time was using an insect biochemical composition growth media to get the bacteria up to a level where we could detect it, rather than using a mammalian-based growth media, which is what microbiology labs all around the world had used up until then. And that got named Bartonella alpha proteobacteria growth media. NC State patented it with myself and the postdoc in the lab at that point in time. And that technology actually became the basis for my son, who was in law school over at UNC, to say to his father, hey, Dad, you keep talking about this bacteria and you keep talking about this patent. Can we use it for this business course that he was then taking, and talk about whether there's a business here? Sure. And I said, help yourself. So that actually is how Galaxy came to be, is as a result of that business course. There was a competition in the second semester that's called the Carolina Challenge. And unfortunately, we came in second and not first, because first place got $50,000, but second place got $5,000. And that actually paid for the initial paperwork to start the company. And so that literally, that journey over 25 years was how Galaxy got started. And as you know, Nikki, and others who know me, I had never had any intention of starting a company. But looking back on the journey and looking at what we've accomplished at Galaxy Diagnostics, I am not sorry that we initiated starting the company. So Galaxy has developed and brought in other technology to be able to detect DNA or proteins, antigens, to actually say that someone's infected with Borrelia burgdorferi or rickettsia or Anaplasma phagocytophilum. Again, the focus, or Bartonella species, obviously, the focus has been on primarily the vector-borne organisms that are tick transmitted or flea transmitted. But I think as we have, and others have seen the expansion of this concept that chronic inflammation is the basis of so many diseases. And clearly, chronic infection is a reason for chronic inflammation. And vector-borne organisms, by their very nature, have to stick around long enough to get picked up by another vector to be able to reproduce and, continue their progeny. Galaxy hopefully will continue to add to the menu of predominantly intracellular organisms that can persist in cells and in the body for long periods of time.
That's really excellent. And it's such a cool story and a really cool journey, and obviously a lot still to learn. But the point you make is such a great one. And it's that there can be a number of reasons why there would be inflammation in the body. Infection is a known and accepted reason for certain inflammatory states, but not for others. Particularly in human medicine versus veterinary medicine, where there are a few vet shows we like to watch with our kids. And I'm always really kind of amazed at in the differential for a veterinarian, how often infection is in there, versus human medicine, where it can be presumed that autoimmunity is an incredibly prevalent thing on a broad scale. And when you really think about it, does it make a great deal of sense that so many people's immune systems are evolving toward essentially attacking their own tissues and, wanting to generate these substances spontaneously or because of genetics, when it would appear that infection, and particularly intracellular bugs, right, that are, like you pointed out, hard to identify, really hard to get rid of because our antimicrobial drugs don't always accumulate nicely inside the cell. And so tell me, what was the thought process? So if you went to get tested for Bartonella, what's the problem, or Borrelia? Talk to me about what the problem is with what's currently available in the marketplace with regard to those germs.
Well, the three major modalities for diagnosis of any infectious disease are, one, culture. And, I think historically, most of the effort in culture has been devoted to culturing easy to grow bacteria. And obviously those easy to grow bacteria are very important, but I also think oftentimes they're secondary infections to a person having a suppressed immune system, or a person having cancer, or a person having another infection. Something as simple as a person having a traumatic injury and getting a superficial infection with staph or strep. So the intracellular organisms, because of the difficulty in culturing them, and viruses would fall into that category, have relied on the development of molecular techniques to be able to detect their DNA or their RNA. And so that becomes the second modality, the one that was kind of there in between culture and our use of DNA diagnostics, was looking for proteins, because if we could get the organism, we could find a protein and we could make an antibody against that protein, then we could combine some things and say, there's actually protein of this bacteria in the blood, and that would say the bacteria is there. So there's what are referred to as indirect tests for infectious disease, and then direct tests. The indirect tests are essentially antibody-based tests saying that the person has been exposed, but an indirect test cannot say that the organism is present. So the other two modalities, either culturing the organism or detecting proteins or detecting the organism's DNA, are the modalities that allow us to say this patient actually has this organism in their blood or in their tissue at this point in time.
Right.
And in the context of us doing research with infectious diseases, and in the context of clinicians understanding what infections can actually do in their patients, serology can be helpful, but it can also be very confusing. And if it's confusing, it becomes very controversial. So, direct detection doesn't solve all those problems, but it eliminates the argument. It's kind of like going to a crime scene and getting a whole bunch of circumstantial evidence and then trying to say that person did it. But if you go to the crime scene and you find DNA of the person at the crime scene, then you know that person was there. And it's a whole different.
Kind of what you're talking about too is like finding DNA and a video, of them doing the crime. That's kind of like this idea of multiple means of saying, okay, the pathogen is here. And the other problem, and I asked this question when I initially was diagnosed with several chronic infections, including Lyme, I asked, well, how do we know it's gone? And you can't do that with indirect methods either. I mean, you can't currently, it's very difficult with stealth pathogens to say, okay, you had the infection and now you don't. And of course, the literature says that a lot of people that contract Borrelia burgdorferi, even after they receive the CDC recommended course of tetracycline antibiotics or amoxicillin or a macrolide antibiotic, you may still be able to actually grow live spirochetes out of individuals, even after long-term therapy. So it's, speaking to the sort of the difficulty in finding that they're there, and then also the difficulty in getting rid of them.
So treatment for these organisms is, as you've just said, Nikki, is extremely challenging. And we've known that with a variety of intracellular organisms. You mentioned mycobacterial infections, tuberculosis, brucellosis, Coxiella burnetii. And I truly believe that, Borrelia and Bartonella fall into that category where, again, it goes back to where we started with this conversation in COVID, is most of us with healthy immune systems do not allow that infection to establish in our bodies. It's essentially eliminated, at the superficial surface of inoculation. But once it does start to get established, then not everybody is capable of eliminating the infection. And that's where and I think the other thing that you said is so accurate and so true. It's hard enough to prove these infections exist before therapeutic interventions. And the problem we frequently have on a research basis is we're contacted, or on a diagnostic basis at Galaxy, after people have failed so many therapies, oftentimes involving multiple antibiotic regimens. And now the question is, can you give us direct evidence of infection still?
Sure.
So it was harder. It was easier before treatment, but it's harder now that the patient's been treated because you've suppressed that infection even more.
So Ed, wanted to tell you a little story from when I was going through the craziness of trying to get a diagnosis. When I was sick, one of my symptoms were these horrible pulmonary symptoms. I couldn't breathe. A severe refractory asthma ended up being the diagnosis. And, pulmonary function testing revealed that it was very worrisome. I had a few different pulmonologists, and one of them, we were getting to the point where we were talking about doing a bronchoscopy, going down and getting a sample and then testing that to see what was going on with my lungs. And I raised atypical pathogens, because I started to do some of my own reading for fear that I would just continue along this mystery diagnosis path from one doctor to the next. And I brought up the issue of chlamydia pneumoniae, which is an atypical bacterium. And he said, we never find chlamydia, really. And what's now 6 years later, that we've started this research consortium and I talked to thousands of scientists, I realized that intracellular pathogens, they really won't be detected leveraging standard means, because especially if they're obligate intracellular, they need to grow inside a human cell.
Absolutely.
So you're not going to just culture it out.
Right.
So they're going to be hidden. And even if they are a disease-causing agent there in the background, like you pointed out, in patients with COVID, I've wondered for a while during the course of the pandemic, what the polymicrobial landscape is in people that have severe response to COVID. And I'm sure you wonder the same thing.
Absolutely. Yeah, there actually was a manuscript that someone sent me a couple of days ago where looking at a large number of people with toxoplasma antibodies. They actually showed that having antibodies to toxo was a greater risk of having a severe COVID infection compared to some of the other known risk factors, such as diabetes. So I've clearly wondered that in regard to a lot of intracellular organisms that we are increasingly being able to prove persist in humans for long periods of time. And I don't think it would be too much of a far-reaching conclusion to suggest that some of these individuals that deteriorate rapidly, and particularly those that develop vasculitis and thromboembolic phenomena, it's because not only do they have this virus, but they've got something that was there before the virus ever came along, circulating in their blood or in their endothelium.
And that may go back to the vulnerability piece, right? And the host response piece, you know, where
Absolutely.
you have sort of a multiple hit phenomenon, where you have several things stacked against you, you know, different infections, their inflammatory nature, and then adding on another infection, and then adding on, you know, genetics that predispose you either to have a higher load of infection or to have a really violent response to the infection, like a robust immune response. So it's all, you know, incredibly interesting and important. And, you know, so one of the things I wanted to ask you too, now that we're talking about, you know, different infections, and you brought up toxo, is recently there was a paper that you helped to publish on Bartonella infection in schizophrenia. I wanted to ask you about that.
So once we started testing veterinarians and veterinary workers, it was pretty obvious that a subset of these individuals had serious neurological problems or serious psychiatric problems. A lot more of them reported in a study we actually did with Duke, where we did the testing, and Duke entered all the participants into the study, so we were completely blinded, is that if a veterinarian was PCR positive to Bartonella, meaning there was DNA of that bacteria in the blood at the day that the sample was pulled and the questionnaire was filled out, we reported an increase in anxiety and aggression. So that was kind of the basis. And then and I think for every scientist, there is always some experiment or some patient or some individual that pretty much changes the whole direction of research. And for us, it was a young man with pediatric acute onset neuropsychiatric syndrome, which was a case report that we published in Central Nervous System Disease in collaboration with a number of physicians that treated this young man. And what was really important there was he essentially failed all the medical interventions for treating depression, psychoses, and ultimately was diagnosed with schizophrenia. And once we found Bartonella in his blood and he was actually treated for the Bartonella infection, he was off of all those drugs within 6 months and had total resolution of all his prior neuropsychiatric abnormalities. And we're now, I think, 4 years down the road. He's in college and he's decided to be pre-med. And I know he's in his second year. So that case report stimulated us shifting our human research to inquiries that came in on neuropsychiatric disease. And then that also facilitated conversations with colleagues at UNC, and particularly Dr. Flavio Froelich, to initiate a study to try to see whether we could find Bartonella in patients with schizophrenia. And not only did we find Bartonella in the UNC patient population, but statistically, compared to the controls, they were more likely to be infected, and it was actually 60%. It was a small study, it was a pilot study, and regrettably it got interrupted because of COVID. So We had to make a decision whether to stop the study and wait until the pandemic went away, or publish what we had at that point in time and try to initiate a new study. So we are in the process of initiating a new study.
I mean, that case is just remarkable. The young man who's now in his second year of medical school. And I mean, it's, the whole thing is, in medical research, there's a propensity to say, oh, it's an N of one, right? To sort of slough things off. But I always think that an N of one is incredibly important, especially if you take a horrific disease, that typically, like schizophrenia, which can be incredibly refractory and challenging to manage, and the medications used to manage it can be very deleterious and cause all sorts of other health issues in and of themselves, like weight gain, type 2 diabetes. A lot of times these people and their families suffer a great deal. And, the idea that an infectious agent can be a cause for one patient should be enough evidence that we should screen for these infectious agents in other patients, and that we should really start thinking more broadly. Ed, you guys have talked about Bartonella, we talked about Borrelia, but then we need to think about other neuropathogens, that have the ability to either enter, the CNS and get there, and that we know have the tools in hand to do damage or to initiate a cascade of inflammation. And we have methods, right, Ed, to detect pathogens, but we just really aren't thinking of neuropsychiatric diseases right now in this way, largely, broadly.
Absolutely agreed. I think what I would predict that's going to change. And I think it's going to fortunately change somewhat dramatically, because we do have improved techniques to be able to identify these organisms and have direct detection. They are not perfect, but the progress that's been made literally in the last 10 to 15 years is like the type progress that it took to get us to the moon the first time. We need a lot more progress, because we're shooting to get back to the moon, or we want to get to Mars and Venus. But I think it will be so important and so revolutionary if we can identify a specific group of organisms that are likely to be intracellular organisms that can contribute to cardiovascular disease, musculoskeletal disease, neurologic disease. And again, whether we talk about Borrelia burgdorferi, Bartonella, some of these other organisms, they can involve multiple systems in the body, because they can get through the bloodstream or go through connective tissues in our body and redistribute. I won't say willy-nilly, but at least whenever they have the inclination to try to do so, and that host immune response can't stop them or control them. So I'm very, especially you alluded to, Nikki, the family. And again, for this boy, they had spent, or their insurance companies had spent, over $400,000 on medical interventions before Bartonella was found in the blood. And he had been evaluated by 4 psychiatrists. He had been institutionalized for 2 months in a specialty hospital for a whole spectrum of tests. So there's the monetary part that this is costing society. And then obviously there's the emotional and total disruption of the family that occurs. They had gotten to the point that this boy was homicidal and suicidal in his tendencies. So, the mother would sleep with one of the sons and the father would sleep with the other son. The family ultimately got rid of their pets. They had a couple cats and a dog. Because the boy felt threatened by them, or they felt that the boy might injure the pets. So, I think, again, as a veterinarian who's an infectious disease researcher who's now looking at neuropsychiatric illnesses, the impact on the families is perhaps the most important part of what I'd like to see go away. And if we can make it go away by identifying specific infectious agents and having directed targets that eliminate those agents, then I will have accomplished something important in my career.
Well, and I'd argue, you are, just by continuing on every day, publishing the things you guys have been publishing, the innovation that's coming out of Galaxy, and, just really honored to have had this chat with you today, and to discuss these really important topics. And hopefully, Ed, the goal is, right, for all of us that work in this field, is for people just to start thinking a bit more about root cause, right? Because whether we talk about germs or we talk about other drivers, really getting down to the bottom of where things begin is so key. So, just an absolute honor to talk to you, Ed, and to capture the story of how things got started for you with your work and how they're unfolding. And I really do appreciate it. Thank you so much.
Thank you, Nikki. It's been great chatting with you.
Great. Take care, Ed.
Bye-bye.
Bye.